you. Okay, so do your reviews, do your teacher reviews, look at these supplemental handouts. I'm going to go through the homework, but before I do, I just, is there any questions right off the bat, like a burning question from the homework that anybody wanted to talk about first? If not, I'm going to try to go through. I mean, I don't hopefully have to read every answer to you from the homework. Some of it's self-explanatory. Just make sure you type here in the chat. Okay, for question 1, so hopefully you have your homework in front of you. Am I recording this? Yes, I should be. Okay. For each reflex, describe how we perform and what we're looking for. So for these reflexes, you need to be able to say, you know, and the way I think about it is, how would you tell someone to do it? So remember palpebral, which is the tapping on the corner, and it says, what are we looking for? We're looking for a blink, okay? And now it does change during anesthesia, but for this part, I'm just like, what are we assessing? And a blink, we are assessing a reflex. And again, in anesthesia, they're going to lose that. Now, corneal is where you actually touch the cornea. Now, in horses, they talk about dripping, like the eye lubricant, drip it on the eye, like eye drops. And you're looking for the eye to retract in the orbit or a blink. The other way you assess corneal reflex, you take a moistened Q-tip and very lightly touch the cornea. So I've seen it done both ways, but you are looking for a slight blink or retraction of the eyeball. Now, corneal reflex is a reflex. They're both an indicator of brain function, because the brain's ability to control a reflex is an indicator of, you know, we're anesthetizing their brain function, basically. So do they have these capabilities? Pedal, pinching, we're looking for, so pedal reflex is a withdrawal reflex. Now, withdrawal pertains to a lot of different areas on the body, but when you pinch between the toe web, you're going to look for withdrawal. And then swallowing, obviously, how do we assess this? This you would be observe the neck for swallowing or visualize in the oral cavity. The thing that I stressed is, in the middle of a procedure, you're not opening the mouth and looking for them swallowing. So when they're laying on a table, you're going to observe the neck and look for any swallowing in the neck. When you intubate, you're going to be looking back there and you can look to see if they're swallowing. But after that, you're going to have to visualize the neck. And the same with laryngeal. Laryngeal and swallowing kind of go together. Observe the neck. Or, you know, laryngeal, if they close, they have an intact laryngeal reflex. And then pupillary is looking at the pupil of the eye. So if you shine a light, they should constrict. That is an assessment of brain function. I mean, in a way, you're assessing all of the nervous system. Now for each stage, and bop in when you have a question, raise a hand, do whatever. Probably type something in the chat because I can't see everybody's screens. For each stage and plane of anesthesia, describe what we see that indicates that stage and plane. Let me get to that slide. Okay, on slides 5 through 8 here, this is where it answers, you know, in stage 1, I want you to be able to tell me, what do you see? So stage 1 is like, they can still be voluntary moving. Think about this. When an animal walks in surgery, for you to start working on them awake, they're in stage 1. When they are heavily sedated to place their catheter, they're still in stage 1. Stage 1 is very broad. And it's basically, they are still conscious. If they are sedated, like if you give them a pre-med and they're falling asleep, they're still in stage 1. They're just in a different level of stage 1. So they can be excited, fearful, sedated, struggling. But again, usually their vitals can be somewhat increased. Now they can be decreased. It says increased heart and respiratory rate. It's going to depend on what you gave them. Sometimes they're nervous and they're kind of like, I'm in a cage, I'm in a strange place, my mom left me here, where am I? And you're going to see some of this nervousness. But this is why we pre-med them, to hopefully calm down their nerves. So does everybody understand that stage 1 is very broad? I can't tell you how long stage 1 lasts. It's different for every patient. But stage 1 is right before you give the induction agent. So whenever you start to, whenever Dr. Ritz or Dr. Paul says knock them out, when you start pushing that propofol, then they're going to start to leave stage 1, and they're going to go. Okay. Stage 2 is the stage that should be very short. I can tell you about stage 2 because this is the excitement phase. This is when they're going from conscious to unconscious. Think about it like you've got heaven and hell and you've got purgatory in the middle. It's kind of like, how are we passing through? But if we're going from awake or sedated to completely unconscious, this stage is a little unpredictable, but this is when breathing gets irregular. I said, sometimes I give propofol and the patient goes, like they start sniffing weird and looking around because they're like, what's happening? A really good induction, if you have a good induction, you're going to go through this stage. You may not even see it. If I have a good induction, I go from sedated to completely asleep without a problem. But I've seen people give propofol too slow or not enough, and then you get this paddling. And I had this dog like scream out, howling. I had to of course it was a husky-ish thing, and I had to grab its mouth shut and kind of hold it, and I just was rubbing it and talking to it, and I just told the student, I said, push it, push it, push it. So I started pushing faster, and I got the dog through. But that little stage 2 is excitement, vocalizing, increased respiratory. They are not conscious control at this point. That's why if you have a dog that's slightly aggressive or thrashing, if they bite you, they don't know they're biting you in this stage, which means they don't always let go. Usually an animal that bites, when they're conscious, they let go. Just, you have to be careful. I've seen dogs thrash. I got hit up the jaw in this stage. So, as mad as I was, and I was like, oh, that was a good one. He didn't do it on purpose. So you have to control them. And then as they come out of stage 2, they're going to get into this relaxed, which is stage 3. Stage 3 is the beginning of surgical anesthesia. They are unconscious. But remember, stage 3 I have on the paper is PL1, PL2, plane 1, plane 2, plane 3, plane 4. Stage 1 is I want you to, their regular respiratory, they shouldn't be moving. At this point, we should be muscle relaxed, eyes rotate ventral, other reflexes. But this one key thing, this is where you pass the endotracheal tube. Stage 3, plane 1. Now, I have dogs that resist passing the tube, and I have to give them a little more. Remember, some animals have this cats, the laryngospasm. So some are hard in this stage to intubate, but this is where we intubate. This is not adequate for surgery. So those are 2 key things to know. Intubate, not ready for surgery. They still may have a little blink. Reflexes should be diminished. This chart that I sent you would be good for understanding how things change in these different stages. So I would look at this chart. And then stage 3, plane 2, this is surgery. So respirations are shallow, starting to regular. Blood pressure, heart rate are going to start to come down. This is where everything kind of goes up. But in this stage, we kind of start to level. They should not have any reflexes, any pedal, any swallowing. This is where the eyes rotate ventral medial. It's one of my favorite things to ask. I only talked about the eye for an hour, not exactly, but close. I've hopefully impressed upon you how important that rotation is. This is where it rotates. Remember, we're awake looking at you. Ventral medial surgical anesthesia. If we stay deep, we go back up. So this is the stage where they're ventral medial. Sometimes you look at the eyeball and you almost can't even see it because it's rotated so down. You just see whites of the eye. That's fine. Perfect. That's what we want. Stage 3, plane 2, they're, unconscious, everything is sluggish. Stage 3, plane 3 is considered the deep anesthesia. So remember, we call it light, medium, deep. Medium is surgical anesthesia. Light, too light, and then deep, your animal is going to probably survive this stage. Everything is just going to continue to slow down. So increased CRT, they're going to be a little dilated, very relaxed, flaccid muscle. This is just excessive anesthetic depth. And again, an animal is going to survive this, but we know that we are hurting cardiovascular function, potentially, respiratory function is diminished. We can get acidosis. This is when we're going to start to see more of the side effects, and we can turn them down. And then stage 3, plane 4, this is overdose. Katie, amen. You want to live in stage 3, plane 2. That is your goal. And that's why I'm constantly turning that little dial of the anesthetic, is because when they start to get a little, everything slows down, everything's going down. I'm like, well, let me turn them down. Well, then all of a sudden their heart rate comes back up, the respiration. I'm like, oh, no, go back to sleep. And, you'll find, I have a hard time with some patients. Sometimes I find that happy medium, and I find 1.25% is perfect. Some patients, they can't get them below 3%. You see, so you just have to kind of play with the vaporizer. But stage 3, plane 2 is where you want to be. Dilated pupils, eyes are going to start to rotate central, which they're going to start getting more of an abdominal effort. When the abdomen is recruited for breathing, the brain is trying to tell the diaphragm, like, we got to get some breathing going. So the body's detecting that respiratory depression is too deep. And then stage 4, overdose. Respiration stops, circulatory collapse. Again, when that heart rate starts to really drop too low, we got to be cautious. So hopefully, I know I spent a lot of time talking about this, but for number 3, surgical anesthesia, the job of surgical anesthesia, not moving, they're not aware, they don't feel pain. The only thing that's weird is this statement is no memory of the procedure. But think about a dog that comes in, has memory of surgery, and then it's time to come to the vet again, and they're reluctant or they're fearful. So I can't say to a dog, did that hurt? Was that an awful dental that day that you had a dental? But again, in people, amnesia, we use drugs that are called amnetics, and drugs that induce amnesia is very important. Just, we don't want them to have memory. What are ways we physically and mechanically, no, every parameter that I've talked about, you have to be able to tell me, how do I physically measure it? Physical is me. So listening, touching, seeing. Mechanical is going to be what machine or what something can I use. So obviously this slide 15 answers number 4. Slide 15, listening to the heart, or, for, mechanical would be like EKG, blood pressure, things like that. So this is a good question. Let me move forward. It says, what are the causes for and how could you treat? Now I understand that these are broad. Here's ways for number 4, I should say 18 specifically addresses cardiovascular. That other slide was addressing overall. These are all the monitors you can use for every parameter. But if I'm listening to the heart, feel a pulse. Again, if your ECG, if power goes out and you're in surgery and you don't have an ECG, you put your hand on the heart, you put a stethoscope in, you feel a pulse, that will tell me cardiovascular function. And obviously you can do the ECG, or blood pressure is going to give you your mechanical assessments. Bradycardia. All animals that are anesthetized to some degree are going to be bradycardic, because all anesthetics depress cardiovascular function. I also, alpha-2 agonists and opioids, those are 2 drugs that are, they're gonna, those patients that may even have a lower heart rate. If they get an alpha 2, this causes the most severe bradycardia. We're doing drugs next, and I'll get into the specific drugs, but alpha 2s, xylazine, dexmedetomidine, cause the most severe bradycardia, but morphine, fentanyl, all do that. And then you just have them too deep. The deeper you keep them, the lower the heart rate, and then adverse effects of the drugs, which the more adverse effect you have of these drugs or other drugs. And also on here, hypothermia. Hypothermia. So how do I treat this? This is easy. Excessive depth, turn them down. Give them an atropine, anticholinergic. So I try to turn them down. I can give them an anticholinergic. We haven't gotten into this in depth, but reversal agents, if you're doing your reading, some anesthetic, if I have a patient in really bad side effects, like sometimes you give dexmedetomidine and their heart rate goes in the toilet, I can give them the reversal agent if we're really concerned that they're in trouble. So I can give them the antecedent, which ironically, anti-sedate, antecedent. It's an interesting way to remember that. Yohimbine reverses xylazine. If you use xylazine, you use yohimbine. And the way I remember that is I used to say, Yohimbi awake now. Yohimbine, Yohimbi awake now. Have I said this before? I probably tried it.
Yeah.
Okay, you guys know my little... Had a student remember that, and you guys already remember it. But the funny thing is, dexdomitor, the drug is antecedent, which I'm like, oh, they're anti-sedate. If they're anti-sedate, they're awake. So you've got Yohimbi awake and anti-sedate, antecedent. They're specific for their drugs. And when we do these drugs, I talk about that. But they're Yohimbine specific for xylazine, antecedent is specific for dexdomitor. But so how do I treat bradycardia? We have to get to the underlying cause. If it's vagal stimulation, remember vagal stimulation is not on here, but if the doctor was tugging on the stomach, which is attached to the vagal nerve, and then all of a sudden he starts tugging and my heart rate plummets, I'm going to treat it with atropine. So atropine will treat drug-induced or vagal-induced bradycardia or hypothermia-induced. Atropine treats bradycardia. Sometimes no matter what the cause is. But sometimes doctors would prefer to reverse the drug than treat it with atropine. It just depends. Tachycardia, it can be from drugs, is a common reason for tachycardia. If you gave them atropine, it's a lot of times atropine. You guys, I'll tell you, in surgery, you usually start with quarter doses or half doses of atropine. Very rarely, I calculate a dose of atropine for a patient. I usually end up giving a quarter to a half of the dose. If that works, great. I very rarely give the full dose. We're doing CPR, I'm giving the full dose. But if they're just a slower heart rate, sometimes I can get, it's kind of like putting salt in a recipe. If I can get away with a half a teaspoon versus a full teaspoon, why not use a half teaspoon if it tastes okay? If they're not deep enough or they're painful, you're going to get tachycardia. They're feeling something. They're getting light. They're waking up. But remember, this is my key thing, is a lot of times when people see tachycardia, they assume the patient is light and they assume that they're waking up and they turn them up. Tachycardia is a response to low blood pressure or hypotension. If you vasodilate the blood vessels, the heart goes, dang, I got to pump faster and harder to fill up those blood vessels. So what does it do? It beats faster and harder. If you turn them up, you're going to make the hypotension worse. So how do I determine, is it tachycardia from pain or being light, or is it from hypotension? If it's pain or light, they're probably breathing faster. They might be blinking. I'm going to check my other parameters. If it's hypotension, they might be a little deeper. Respiration hasn't changed. There's no, you know what I'm saying? So if I just turn them down, it's maybe I turned them down too much and they're too light. So look at your other values. If it's blood loss or shock, you're either going to give fluids or treat with blood. And if it's hypoxemia, hypercapnia, I'm going to give oxygen or increase oxygen and bag them. And hypercapnia, which is elevated CO2, I'm going to bag them. So does anybody have any questions for number 5? Did that effectively answer how you would treat one or the other? Hopefully it does. Okay. Why is it beneficial to use an esophageal stethoscope in conjunction with your ECG monitor? Okay. The main thing, and on slide 22 for number 6, so I'm going to try to give you these slides as I talk about the homework so that you kind of can go back with this video. Esophageal stethoscope is going to be placed in the esophagus, and the esophagus runs through the thorax, and you're trying to put it in the esophagus near where the esophagus is next to the heart. So as the heart beats, okay, I'm going to tell you a funny thing, and I'm not trying to tell you this to confuse you. I've put esophageal stethoscopes, and I've heard ba-boom, ba-boom, boom, ba-boom, boom. It's like a third beat. You're hearing 2 beats of the heart, and the heart bumps the esophageal stethoscope against the esophagus. And you're hearing ba-boom, boom, ba-boom, boom. You can move it a little bit because you're probably just really close to the heart, and it's bumping it against the esophagus. This is probably one of my favorite monitors. Love, 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 because I'm listening. It's too hard to take your real stethoscope and slide under the chest. So all you do is put this in, you pass it blindly in the esophagus. I just sometimes put a little bit of water or a little bit of sterile lube on it. It actually doesn't even have to be sterile because you're putting in the esophagus. And you just listen. The reason I like to use it in conjunction with an ECG monitor is because listening to the heart is going to confirm if you see something strange on your ECG. If you see something on your ECG, interference or an abnormal, baseline interference, it's also going to confirm the heart rate. The ECG always gives you a heart rate. But anytime there's interference, that number is going to jump all over the place. Put in the stethoscope and confirm, is that accurate? If you hear your heartbeat go boom, 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 you're like, what's happening? Then maybe that's accurate. But if you're hearing boom, 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 and I was with a student in the room and we saw this. She was like, what is happening with Sangaros? And I'm like, don't look at that. Put your ears in. And then she goes, oh, that's totally different. It's not even doing that. And I go, exactly. You have interference. Everything's fine. So it's going to confirm. And then I have on number 7, be familiar with sinus arrhythmia, first, second degree. So these are all slides. Well, there's the esophageal stethoscope. There's the electrical conduction system, normal. Starting on slide 26 is where number 7 goes into. But remember, and this kind of leads to chapter 1 too, because remember that stuff's on the test too. I talked about, do you need to confirm a sinus arrhythmia with an ECG? No. If you hear the heart speed up and slow down and you feel the animal inhale and exhale, totally fine. Bo has major sinus arrhythmia when he sleeps. And I'm like, he's super chill. Heart rate's in the 52-ish range when he sleeps, but it always speeds up when he inhales. And as long as it's doing that, it's fine. Now, it has a note here, abnormal in a cat. But I'm going to tell you, most cats are heart rates in the 180s to 220s. I had a cat once that was in the 140s, and I was like, oh, okay. That's interesting that it was so low, but it was very normal when it was low. First and second degree block. Now there's something sinus bradycardia. Sinus bradycardia is still normal. Sinus bradycardia is just a slow heart rate. And it says abnormally slow. But what I'm saying is sinus bradycardia could be from dexmedetomidine. It could be that they're too deep. It's a normal electrical impulse. It's just telling you that they're very, very deep. Consider reversing them. and consider giving atropine. Now, sinus tachycardia, it says abnormally fast heart rate. Don't read this abnormally and think it's the ECG that's abnormal. They're telling you it's either abnormally slow or abnormally fast. It's a normal ECG, just a slow ECG or a fast ECG, which I've told you how to treat bradycardia. When you see sinus next to them, normal sinus rhythm. NSR, normal sinus rhythm for both of these, they're just fast and slow. When you get into the blocks, now it says on here, be familiar. What I'm saying is, what is it characterized? First degree, remember, is the PR interval. It's a normal, well, you have a PQRST complex. It's just the P to the R is too long. Okay, it is a bradyarrhythmia. Second degree is a P without a QRS. And then third degree is multiple Ps. Atrial fibrillation is the base. Sorry, this shows you the different ones. Supraventricular tachycardia is fast. I have ventricular, VPCs. So this is where you have, this is an abnormal electrical conduction. And it's basically, if you look on here, it's explaining that you've got this PQRST and then you've got this kind of wide and bizarre, kind of upside down-ish, you know, but you should hopefully have some normal PQRSTs in the middle of these. You could get runs like this, and obviously if you got this, it's ventricular tachycardia, which would need to, now that's treated with lidocaine typically. This is not something we usually treat with atropine. And again, I'm not treating something like this without talking to my doctor. I have given atropine before to a patient. Had been given that authority. Christine, if it's too slow, give an atropine. And I'm like, okay. So, but that's just for like a normal ECG and just a slow heart rate. If I'm seeing these arrhythmias, usually the doctor's getting involved. And then fibrillation, the two kinds are atrial and ventricular. Atrial could potentially be treated. It is not an emergency, where ventricular fibrillation is, there's no coordinated electrical activity. And then the PEA or EM, I call PEA EMD, pulseless electrical activity, electrical mechanical dissociation, but that's where you have a normal ECG but no audible heartbeat. That's why I get so concerned about the ECG, is that if this can happen, take your ECG with a grain of salt. You should always be listening. As long as you hear a heartbeat, the heart is working. But this is where the ECG is normal and the heart has stopped. So let me, CRT, which is refill, is an indicator of perfusion. Question 8 is slide 38. It's basically, it should be less than 2 seconds. If it's 2 seconds or greater, but it could be low blood pressure. It could be they're cold. When they're cold, their gums or their periphery vasoconstricts. So you're not going to have as adequate blood flow to the body is shifting the blood to the core. The colder they get, the more the blood goes to the core to keep the core warm. It could be blood loss and shock, so just be familiar. Reasons it can be extended. Okay, this is what I'm telling you. What does blood pressure measure? This is basically blood exerted on the arterial walls, particularly coming from the left side of the heart. Okay, because there's arterial blood flow in the lungs. We're primarily measuring systemic circulation. And it says, what is the difference between systolic and diastolic pressure? Basically, systolic is pressure during systole, during the heart contracting. Diastole or diastolic pressure is when the heart is relaxing. So it's the difference. And again, that's why your top number of blood pressure should always be higher than your lower number, because if your heart is not contracting, why would you have pressure in your arteries? Again, it's very rare that those numbers are close together. except if you overdose fluids. If we have fluid overload, that would potentially increase diastolic pressure. And then the mean is the average through the cycle. The handout that, let me get to it for a second. There is blood pressure. It says normal is 120 over 80 under anesthesia. The mean, it can be, it says between 70 and 90 in that handout, but the minimal acceptable is 60 for a mean. So remember I told you to know that. To maintain perfusion to the kidneys, mainly because they're excreting the drugs. Okay. Peripheral, number 10, peripheral arteries to palpate a pulse. Be able to tell me lingual, femoral. This is the carpal artery. You have the dorsal pedal on the back leg, ventral tail. Carotid is going to be difficult. Facial would mostly be if we're getting into a horse. Oral, ear, rabbit, or a pig, that works for as well. And the reason it's subjective, again, I've explained that your hand's cold, my hand's warm. Where did you put your hand? Things like that. What's the difference between direct and indirect? If you see direct blood pressure, there is a catheter directly in an artery. And if you see indirect, this is an estimation. So direct, like I said, you're going to have to be in like a surgical referral practice or research or equine hospital. Again, we did this at VCA, did this all the time at Purdue. Definitely working with horses, they do a lot of this. It is the most accurate, the gold standard, and the indirect is the cuff over an artery. You can do this two ways, oscillometric and Doppler. Oscillometric is the machine, usually with the ECG. You put the cuff on, you hit the button. You can set it to read every 5 minutes. It'll, all of a sudden you'll hear this little thing goes, and it puffs up the catheter, and then, or it puffs up the cuff, and then it gives you a reading. And you can set it, the Doppler is the little crystal over the artery. And I had sent you videos of these. So it's direct and indirect. I don't think, I said, don't worry about CVP. What are 2 reasons for hypotension and hypertension? Let's see. It does not. Oh, slide 39. There are some notes underneath this slide about hypo and hypertension. Remember, if the heart is just a pump and it's attached to tubes, which are vessels, if there is low blood pressure, which is pressure in the vessels, there's something called preload and afterload. And preload is the blood coming to the heart, which dehydration can affect that. Blood loss can affect that. Afterload is the resistance, the vascular resistance of the tubes that it's pumping into. If you have vasoconstriction, it's going to be harder for that heart to pump. If we have vasodilation, it has to work harder. So remember, hypo and hypertension, you can't always blame it on the heart. I'm going to say hypotension is going to be increased anesthetic depth or vasodilation from agents. Propofol is a big vasodilator. Well, a lot of anesthetics vasodilate. The majority of them vasodilate. Isoflurane, sevoflurane, propofol, acepromazine. You're going to hear me say vasodilation when I talk about drugs a lot next week or this week. If they vasodilate, there's not as much pressure in there, is there? Because it's a bigger tube. If we have hypertension, which is high blood pressure, now, most of the time that's associated with pain and them being too light. If the blood pressure spikes, they're too light. Hypotension, Caitlin, hypotension can be vasodilation from drugs. Increased anesthetic depth is going to make their blood pressure drop. So they're too deep They can also be dehydrated or have had blood loss. Okay. Hypertension is typically increased anesthetic depth or decreased. They're too light. They felt pain. You know, your blood pressure goes up if you hurt. It can be they have organic hypertension. If you have high blood pressure, you're going to have high blood pressure during surgery. I am often battling hypotension. And I think, number 13, how do we treat hypotension? Because this is almost my number one battle. Turn down your anesthetic, number one. Turn down your anesthetic. Because a lot of times they're too deep. Increase your IV fluids if you can. So sometimes we'll give them a little fluid bolus because these animals are fasted and they're vasodilated. If you push more fluids, hopefully you can boost vascular volume. That will increase the pressure in the vessel. So increase fluids, decrease. Now, my third option, and this is where the doctor needs to get involved, we have drugs that will increase blood pressure. I will talk a little bit about, but we give dopamine. There's a drug called phenylephrine. Now these are, so I would just say use blood pressure increasing agents. I'm not asking you for the individual agents because those are very special circumstances. You don't just give these drugs willy-nilly. So I've never really seen them used in general practice. I've used them at Purdue in special cases. In emergency medicine, we've used them in some special cases, but there's drugs that will increase blood pressure. But I usually always start by doing, giving some pain meds, and I can turn the anesthetic down. I can push some IV fluids as long as the patient does have pulmonary edema or heart. If you have a heart disease patient, you guys have learned what patients can't handle IV fluids. I hope you learned that in Tech 4 or whatever. Okay, so not every patient can just get a slug of fluids. So you got to make sure your patient can, most every patient can handle it. Okay, wow, 10:48. Oh, we just have a couple more sheets. We're getting there. Okay. Mechanical, physical ways to measure oxygenation. Obviously, let me get to this slide, sorry. Okay, eyeballs, look at the gum color, assess gum color, evaluate, you know, the color of it, how fast this, you know. Correct, Katie. So in heart disease patients, we're fluid cautious. Kidney disease. Now, some kidney disease, you do push fluids, but you got to determine what level of kidney disease and where they're at. But I would say if you had elevated renal enzymes or we suspected cardiac disease, a lot of times if I have a heart disease patient, I run half the rate of anesthetic fluids. I cut it in half. I back off. Just so we don't overdo it. So we're very cautious. So thanks for saying that. So look at the tongue, look at the prepuce, look at the conjunctiva, like pull down their little eye. So you assess that by visualization. Again, tell me what colors mean on a test. It says pale or cyanotic. So if they're pale, and it's, you know, that could be blood loss, that could be they were anemic, but it can also be sometimes they get pale because of drugs. Dexdomitor makes them look very pale. So if I am using Dexdomitor and they're pale, I'm not freaking out. I'm like, that's the drug. If they're cyanotic and blue to purple, it can be they're not, you know, is it respiratory arrest? Are they not, are they so low respiratory rate? That's pretty rare, but it usually indicates they are not getting oxygen. But it can also, all of these can be affected by, they're cold, they're going to be pale. If they have increased vascular resistance from drugs, they're going to be pale. If they have gum disease, they're going to look being bright red. 2 ways oxygen is carried in the blood. For number 16 is slide 49. Number 16 is slide 40. Wait a minute. Yes, right here. There's free oxygen dissolved in plasma. It's like I'm free and I'm floating in the plasma. And then the majority of oxygen is bound to hemoglobin. It's like I'm stuck to hemoglobin. That's most of oxygen. There is also dissolved oxygen in the plasma. Again, when we measure SpO2, we're measuring oxygen bound to hemoglobin. But it says on number 17, what does SaO2 and PaO2 measure? You're going to do SaO2 and PaO2. PaO2 is the oxygen dissolved in plasma. Pa, when you see A, that's a blood sample. You cannot get this value without taking a sample from an artery. If you get it from a vein, it's going to be lower. Why is this number going to be lower if you accidentally hit a vein instead of an artery, which happens? Anybody have an idea of why? If I hit a vein, thank you. If you get a venous sample, veins carry deoxygenated blood. Now, like I said, there was a time, I swear I hit the artery. He wanted a blood gas. I got it. My boss gets the values. And I look at it first and I'm like, oh my God, this dog's doing really crappy. But I'm like, this dog doesn't look like she'd have this low of an oxygenation. And he looks at me, he's like, Christine, you probably hit a vein. And I'm like, no way. And he's like, you hit a vein. Because, like I said, I've been fooled before. Bright red, Ashland, bright red mucous membrane color comes from like toxicities. If they're septic, if they're hyperthermic, they're going to have those injected mucous membranes. But it also comes if they've got crappy teeth. So if they, sometimes their gums are inflamed just because they have really bad dental disease. But if they don't have dental disease, and I know that they have a septic abdomen, a lot of times like they come in this toxic shock type state, then they're going to be bright red. And that's when you push on the gums and it comes back in like a millisecond. They're almost hyperperfused. Okay, SaO2 and PaO2. SaO2 is the hemoglobin saturated with oxygen in an arterial sample. Okay, that's what the A comes from. So SaO2 and PaO2 you have to get from an arterial sample. Most of the time though, you guys, let me skip ahead, is to the pulse oximeter. You guys are going to get an SpO2. If you see the P, that comes from pulse. So SpO2 is a pulse oximeter, which is an estimation of oxygen bound to hemoglobin. That's what the pulse oximeters, they're not measuring dissolved oxygen in the plasma. It is what is bound to hemoglobin. This full sheet, this handwritten sheet goes over, remember 95, it says for 18, normal is 95 to 100%. That's cross species. Yes, Melissa, that's perfect. Everybody, I would put this, copy it, shrink it, put it in your little nerd book, put it in your little clipboard, okay? I would keep this. I should have made you do this by hand, but I did it for you. Anyway. So 95 to 100 is normal. 90 to 95% probably needs to be investigated. Your patient's probably okay, but something's going on. If we are the 85 to 90%, you need to start ventilating that patient to see if you can improve that value. And then if it's lower than 85%, that is an emergency. You need to potentially discontinue surgery, bag them, get the doctor involved. But I gave you several reasons. So I have, I didn't ask this as a question because it said, where are 2 locations to place a pulse oximeter probe? Tongue, prepuce, I think I have that. Maybe I didn't put that on there. But, be familiar, talks about, tongue, pinna, in between the toes, the Achilles. The light is shining through and then it's bouncing back. If it's saturated with hemoglobin, it reflects the light back. What percentage of light is being reflected back? That's how it gets this value. Reflective would be in an organ. So this is the clothespin. And can you hold on 1 second? Okay, so the clothespin, the light should shine from underneath. Okay, the light should be underneath. The reflective can be placed like in the rectum and things like that. So be familiar with locations, and then be familiar with how to troubleshoot, because again, it could be, if it says 87 and it's sliding off the tongue, or it's been sitting in one spot for 10 minutes, or the tongue is super dry, or the tongue or the probe is dirty, you can clean it and replace it. The key here that I've told you is, if you get a crappy reading, I move it 2 to 3 times. I might just take it off the tongue, rub the tongue, put some water on the tongue, and put the probe back on in almost the same spot. But if you can move it to a different spot on the tongue, if you keep getting 92, 92, 92, or 85, 87, 86, I'm like, oh, okay. But a lot of times you move it, clean it, massage the tongue, moisten the tongue, and a lot of times my number goes back to normal. And a little tip is, when you first put it on, it takes a minute or two to get a reading. I don't panic right away. Give it a second and, see what the number comes back at. So be familiar with equipment issues, be familiar with patient issues, but basically, like, if the reading is still crappy, check the probe. Now check your oxygen. Is your tank out of oxygen? Does your bag have a hole in it? Did the tube slide out? If everything is fine, does the patient have pulmonary edema? Do they have pneumonia? The big thing is, after I check the first 2 things, after I check probe, check oxygen, when I bag my patient, force more oxygen, does the reading go up? If I absolutely can't fix anything, it's that thing at the bottom called VQ mismatch, which means it could be a clot in the lungs. I can bag all I want. Unless you fix the clot, it's not going to oxygenate. So I'm going to go through all of these steps to try and fix it. Bagging should fix the problem. Mechanically assessing and visualizing respiration. Well, visualizing ventilation. Respiration is cellular. Ventilation is the patient breathing, but I'm going to basically okay. Can you hear me? I paused for a second. Sorry, my daughter was leaving. I had to say bye. Okay. So obviously for ventilation, watch them breathe, watch how their chest, but remember, not just more than respiratory rate, you have respiratory rate and character. So looking at the character, respiration is going to be deep. Now mechanically, or if it says mechanical, you can use an end-tidal CO2 monitor. You can also use an apnea monitor. That apnea monitor basically just tells you if they're breathing or not. Remember the difference between, okay, now 21, difference between rate and character. Rate is just how many times are they breathing. Character is, remember that IE ratio. If it's like, that's a 1 to 2 or a 1 to 3. If they're like, that's an inverted IE ratio, which indicates increased effort. So how much abdomen are they using? How much effort? What is the term for elevated CO2? This should have been hypercapnia. Slide 64 for number 22 is getting into that. And then it talks, I think I'm missing a sheet on the homework. Because I had 23 as my last question. Are there more questions than that? So 23 is the last question you got? Okay. Okay. I'm going to talk about something else though. So elevated CO2 is hypercapnia. What causes this and how do you treat? So a high CO2 is basically, hang on. Here we go. Sorry, I'm trying to find a good slide that really gets into a lot of what I'm talking about. Sorry, are you guys okay to talk for a few more minutes? I know it's 11 o'clock. Do you have to get to another class? All right, just hang tight with me. Hypercapnia, okay, is a high CO2. If you have too much CO2, you're not breathing. So typically hypercapnia is basically caused from increased depth of anesthesia, like respiratory depression. How do you treat it? The way you get rid of CO2 is you can bag them, you can increase ventilation, but if you want them to fix it, you can turn down their anesthetic, or reverse agents so they start breathing more often. But hypercapnia is, for some reason, they're retaining CO2. Now, it can be that your soda lime, the little canister that gets rid of CO2, can be expired, and it can be that they're inhaling CO2. But remember, that would be abnormal too. Low CO2 is hypocapnia, or too low. And what causes this during anesthesia? Well, sometimes they have breathed too fast or too often, and they got rid of too much CO2. So basically, the way to treat hypocapnia is you need to back off ventilation. So hypocapnia, it can be, that's usually the patient breathe, and if they were tachypnic because they hurt, then you're going to have to give them pain meds and maybe they won't breathe as often. But CO2, you got to bring it back up. Now, sorry, I don't want to rush here at the end, but what I need to say here is that, remember, apnea is no breathing. Apneustic is where they hold their breath. So the difference between that. The other thing is, I've already talked about the reflexes and how to assess them. Was the end of this, I talked about temperature, okay? And I talked about, I didn't ask a question, which I'm surprised on the homework I did not ask this. You don't have to know pH and blood gases. I'm not doing that. Just know what normal CO2 is. What is normal temperature? Why are they hot? Why are they cold? Okay, obviously I'm going to battle being cold more often. And how do I prevent that? Towels, heating pad, bear hugger. What are the consequences of, or why do patients get cold, is number 81 or slide 81. So tell me why a patient's hypothermic, and then what do I do to prevent that? But the consequences is they're going to sleep longer. So even though I didn't ask a question about temperature, I want you to know that for the test. I've already talked about these reflexes and how we assess it, so you should know that. Okay, I'm sorry, I feel like that was so fast. Does anybody have any questions right off the bat? For monitoring, again, you have all these supplementals. Normal temp under anesthesia. Well, okay, that's a good question. Ashlyn, you just need to know normal temp, which is 99.5 to 102.5. How low it goes is very patient dependent. Like I said, I found out very quick, Dr. Paul doesn't like them below 96 or 97. And I kind of laughed, but I've had patients down to 88. But again, for you guys in there, probably, you know, keeping them above 96 or 97 is going to be better for the patient. Now, anyone have any other questions? You have your material for most of the test. I'm going to say most of this test is going to be this material. It's probably going to be like 75% monitoring with a little bit over chapter 1 and chapter 2. So I would put the focus on studying, but I think the stuff from chapter 1 and 2 is pretty self-explanatory. Okay. So what other questions? Any other? I'm going to send an email out. I'm going to convert this video. I'm going to send this out. It'll probably take me just a little bit. But I will get that sent out. Yeah, I have not heard about anything from SIPES. So if anybody else knows something, if you want to answer Kirsten's question.